Thank you, Professor Wang. And good afternoon, everyone. I'm Dr. Yini Zhang. I'm Yini Zhang from National Taiwan University Hospital, a urologist and an andrologist. And today I'm going to share the topic, platelet-rich plasma and how it works. The definition of platelet-rich plasma is that it is autologous concentration of human platelets, and the PRP should have 3 to 5 times greater concentration than physiological status. The normal physiological status of the platelets are about 150,000 to 300,000 cells per microliter. And to prepare PRP, we can withdraw the whole blood from the patient and put it into a special kit. And after centrifugation, the erythrocytes would be separated from the PRP. And we withdraw the PRP to inject wherever the target tissue we want to treat. And before we look more details of the therapeutic effects of PRP, we can review the platelet function together. When encountering an endocellular damage, the von Willebrand factor and the collagen would be exposed, and the platelet would be activated. And after platelet activation, the cytoskeleton would undergo a rearrangement, and the granules in the platelet would be secreted and released. And the growth factors and chemokines in the platelets would cause cell migration, differentiation, proliferation, and neovascularization. And this growth factor would make more processes of wound healing and tissue regeneration. And now we look at the platelet. There are lysosomes, dense granules, and alpha granules in the platelet. And there are coagulation factors, growth factors, and chemokines in the platelets. And the most important are the growth factors, including PDGF, IGF-1, and VEGF, and etc. And this growth factor would promote wound healing and further tissue regeneration. And if we look more details of these growth factors, the IGF-1 and 2, it would stimulate cell growth and mobility. And the EGF would elevate epidermal cell proliferation, differentiation, and angiogenesis. And the BFGF would also stimulate angiogenesis and cell mobility. And the PDGF would moderate cell replication and tissue repair. And the KGF, it would accelerate wound healing and stimulate epidermal growth. And the IGF alpha and beta would promote cell replication and collagen synthesis. And the VEGF, it would stimulate angiogenesis. And the CTGF, it will enhance the cell adhesion and make bone growth better. And the PRP is first applied in the clinically since 1970s. It was first used in dental and maxillofacial surgery. The doctor found that if they put the bone graft with PRP together, the bone would grow better with a better grafting results. And in orthopedics fields, the doctors found that bone, cartilage, skin, tendon, muscle regeneration is beneficial from the PRP. And when doing the repair of rotator cuff, meniscus, Achilles tendon, they can also use PRP to facilitate the repairing. And PRP is also used to treat osteoarthritis. However, there are very few quality clinical studies with enough case numbers and placebo in this kind of experiment. And further, in plastic surgery and dermatology, PRP is used to enhance the wound healing, like diabetic foot, skin ulcer, including pressure ulcer, venous ulcer, and leprosy ulcer. And PRP is also used for treat vitiligo and alopecia. And in ophthalmology, they use PRP to treat dry eye, graft versus host disease, epithelial defect, corneal ulcers, burn, and post-LASIK syndrome. And in gynecology, PRP is used to treat wound healing, vulval vaginal atrophy, and C-section delivery, and in reproductive medicine. And in ENT field, PRP is used to treat tympanic perforation and vocal cord damage. And in urology field, there are also many target organs that we can use PRP. Till now, PRP is used in bladder, urethra, and penis. And in bladder, PRP could protect the patient from recurrent urinary tract infection. PRP is injected intravesically, like we did to inject botulinum toxin to treat OAB. And after PRP rejection, there is improvement on cytoskeleton and barrier, including CD34, CK20, muscarinic 2 and 3. And in interstitial cystitis, if we inject PRP into the patient's bladder, there was also significant symptom improvement and decreased urinary growth factor, matrix metalloproteinase 3. And it is also used in BK virus-induced hemorrhagic cystitis. And in urethra, there's a study that they use PRP to treat the mid-shaft hypospadia repair, and there is lower urethral stenosis, lower postoperative infection rate. And PRP is also used to treat stress urinary incontinence. In male patient, it is injected at the area of external sphincter, and in female, it is injected at vagina site near the mid-urethra. And there are several animal studies that to discuss about erectile dysfunction and PRP. One of them is conducted in 2016. It is the cavernous nerve crush rat model. The rat cavernous nerve are damaged bilaterally, and the investigators, they inject PRP into the penis, into the corpora cavernosum, and they found that after the injection, there is increased intracavernous pressure and more myelinated axons, and more NADPH diaphragm positive fibers in this injected rate. And another study is conducted in 2021, and they found that after injection of PRP into the corpus cavernosum of the hyperlipidemia rate, they have higher intracavernous pressure, increased NOS, and increased endothelial NOS and better endothelial cell. So in conclusion, that possible effects of PRP in ED is that growth factor may promote tissue regeneration and would increase intracavernosal pressure, increase corpora and endothelial NOS, and increased myelinated axons. And now I'm going to present the preliminary data of the platelet lysats in NTUH. We use the AON PRP, and the inclusion criteria is 20 to 70-year-old male patients with erectile dysfunction. And the exclusion criteria is that pelvic surgery or penis surgery. We withdraw 20 milliliter whole blood from the patient. And after second stage centrifugation to separate the PRP from the erythrocytes and to decrease the leukocyte, because leukocyte might cause inflammations in the penis. So we use the low leukocyte PRP for injection. And we injected PRP into 6 sites with interval 14 days, and we injected 5 times. And the picture is where we injected the PRP. We injected PRP separately at the proximal shaft, distal shaft, proximal shaft, and the cruise. And we record IIEF5, EHS, and penile Doppler. Till now, we collected 18 patients, and 61.1% of them had EHS improvement. And IIEF5 improvement was noted in 77.8%, and about 72.2% patients feel subjectively improvement, such as morning erection and better penetration and the better maintenance. And we also found that the patients with initial IIEF5 more than 11 have better results. 90% of them feel subjectively improvement. So we had a first conclusion that maybe the patients with mild to moderate erectile dysfunction, they will benefit more from the PRP injection. And for some patients, we have completed the penile Doppler and they have increased arterial velocity. And thank you, that's the preliminary data now.
Yeah, thanks for the Dr. Jiang's excellent talk. And any question from the website and from the audience?
How to localize your injection site at the cruise by ultrasound or by palpation or?
We recognize the cruise by palpation, and it will near the pubic bone. So we will ask the patient to open their leg and elevate the scrotum and to palpate the cruise. But in some of them, it's very difficult to palpate. So we use the soft tissue echo to recognize.
Any further question? May I have a question? How many times injection? I mean, only one shoot, or what's the injection interval?
We inject 5 times.
5 times. Okay.
5 times, and most patients feel improvement after 3 to 4 injection.
Okay.
And but I noticed that the patients with improvement, most of them are sexually active. So they still have some erection function, but not so good. And after injection, they improve. But if there is no erection at all in the first, then the result is not good.
Any question? And I have one more question. Do you have the etiology of the erectile dysfunction? I mean, some patients maybe have a psychological erectile dysfunction. Some patients may be vascular ED or venous leak ED. So, any difference in different groups?
Well, till now, all of our patients are of vascular genetic etiology because we did penile Doppler at first. And some of them are arterial factors and some of them are venous factor, but we have not analyzed which type would benefit more. But we have noticed that in the improvement type, they have increased vascular arterial velocity in the Doppler, follow-up Doppler.
Okay.
Thank you very much. Any question?
Dr. Wang, because Chen Guoliang, yes, he has a question on the, he showed can this injection cause scarring and fibrosis?
Till now, we haven't noticed fibrosis, but we will tell the patients that don't make love at the first day we inject. Because one of our patients, they did it on the first day we injected PRP and have fever for 1 day. And the others, there is no scarring and no other consequence. Thank you.
The second question is, how about this patient? Are they use the Viagra or Cialis?
Patients, they remain the treatment they previous use, like when he used Cialis, then he keep the Cialis. And if he used Viagra, he keep the Viagra. And if he did not use any medication, then he just stay at his own status.
So still keep the same status. Okay. Pen.
My question is that, do you use any negative pressure device to keep the PRP in the penis or just injection?
No, we just inject, but there's a study they use tonically. or a clump to keep like PRP inside.
Another question from the audience is, he asked Dr. Jiang, is the procedure neither under the local anesthesia?
Most of them we just injected, but if some patient they feel pain, we ask them to buy the Photocin spray. So they use the spray 5 to 10 minutes before we apply the injection.
Thank you for sharing. I have can you share the thinking process about your study? Why you choose a 6-point injection? Because we know the maybe because our pain is communicated. We more injection site, maybe more scarring, more fibrosis. Why you choose 6 injection site? Can you share?
Initially, I think that if I just inject at the cruise, it may be just go back very quickly. And so I inject at the distal site. But I also inject at cruise because I also worried about that there are nerves there. There are cavernosus nerve. So we choose 6 sites. And also I have to think about whether I should use a clump because there's some paper with the clumping method, like they clump it for 20 minutes. But I'm worried about ischemia, so I just inject. Until now, there's a 70% satisfaction. So I think maybe it's a method. But Dr. Liao, he injects 2 sites, but he also has a very good response.